I think we tend to view time to treatment failure very much like we view progression-free survival. They're both surrogates in the palliative setting for overall survival and for quality of life. I think time to treatment failure, again, is viewed in the context of other data. If we also see improved response rates like we do with Afatinib compared to Gefitinib in the setting of even a trend to overall survival and side effects that are manageable, then the whole picture together makes it practice changing. The lack of overall survival outcome is a bit disappointing, but we have to remember it was a phase 2b clinical trial. It was underpowered really to show an overall survival benefit, so the magnitude of the trend for overall survival was still kind of reassuring. It was going in the right direction, and the benefits of time to progression were also clinically meaningful. They weren't just a matter of days like in some clinical trials. So if we can learn how to give the drug effectively, how to select patients for whom the perhaps added side effects would be manageable, I think it does offer a very reasonable alternative. Many of us have adopted Afatinib based upon the earlier LUX-Lung 7 data as our first-line agent in patients we think can tolerate it. In patients, I think there are colleagues of mine who will often say, because of the diarrhea, the added side effects, or older patients, they won't use Afatinib. And many of us, I think, have decided that we will use it, hoping for that same benefit, but maybe start a bit slower. We're not often in a rush with these patients, so if we can start with a lower dose, like 30 milligrams, and even in 2 to 4 weeks, escalate it carefully and help manage side effects preemptively, we can get half of them up to 40 quite effectively, and the others could stay on 30 may still have a very similar magnitude of benefit. Yeah, I think that's the art of oncology, is how to manage dosing. In clinical trials are very strict about starting at the official dose and going down if we have to. But in practice, I think if we realize that even in landmark trials, half the patients require reductions, it's not unreasonable to start people on a lower dose if we're not in a rush, if they don't have visceral crises or very aggressive disease, and let's see how they do. If patients develop significant toxicities in real-world practice, they may not have the confidence to continue on the lower dose. But if they can start off slow and move up, it's actually more doable. I think it was quite reassuring to see Vera poster from ASCO about the patients who had dose reductions having very similar outcomes. And we've seen that in many different kinds of drugs, in everolimus and capecitabine, that you have to lower the dose following the standard criteria, you still achieve similar efficacy. It was also reassuring to see in LUX-Lung 7 for the final survival analysis that the quality of life also was quite well maintained and not detrimentally affected.